previous speakers who presented some marvellous research and presented the context of yoga and depression. So without consultation with some of the earlier speakers, in fact, my talk has several elements that repeat some of the slides that the speakers have presented. So in those cases, I'm going to push forward to present a little bit more different things. So obviously, just a little bit more about the sort of work that I do. And again, you can see from the way I look, obviously I have an Indian background. I was 1 year old when my parents migrated from India to here. So I have been raised in Melbourne, in fact, right from the age of 1, which is why my accent is an Australian accent. It's an interesting thing for many people who are from a different migrant background and settling in Melbourne or in Australia. One of the things that is an interesting integrative factor is the accent. So we find that in fact people experience less racism in Australia when they actually have a similar accent, and the expressions and the idioms are very Australian. So that's an interesting thing that happens. So for those of you who have children who would be like me, second generation migrants, you'll find that they will speak to you if you have an Indian accent in the house in one way, and then you'll hear them speak in the playground in a different accent as well. So I'm raising this because this is one of the many differences that people find being from a different migrant background, and it is a stress in terms of mental health. It is one of the factors that impacts on mental health, and there is a higher level of depression, anxiety disorders in migrants, in particularly first-generation migrants, but also in second-generation migrants. And so in my clinical work, that is something that always comes up, and that is a factor that we look at. I must also say that being of Indian background and living in Australia has the amazing opportunities of being able to take from both cultures those things that you want and those things that you want to discard. So in actual fact, I feel very privileged to have access to both cultures, and I really enjoy hearing more about things such as yoga, spirituality, which is not something that I practice in my daily work. So as a psychiatrist, I'm going to talk a little bit about depression, but as I said, some of this has been covered, so I'll go through quickly those things that have already been covered. So as said, depression is a very common mental disorder. Globally, more than 350 million people of all ages suffer from depression. It is the leading cause of disability worldwide and a major contributor to the global burden of disease. Its morbidity is actually comparable to angina and advanced coronary artery disease. And of course, unfortunately, there is a high mortality from suicide if untreated. You will have heard some recent statistics that 89 in 1,000 Australians are prescribed antidepressants. This is data that has come from a recent pharmaceutical benefit scheme survey. That's 89 in 1,000 Australians as of November 2013. So this is a very startling figure. It's a very high figure, and it again tells us that there is something very deep and troubling going on in Australian society. 24% of all women and 18% of all men in Australia have been prescribed antidepressants at one time, and the prescriptions go up as the age goes up. So the older Australians, that's 50 plus, I don't think 50 plus is that old at all, in fact it's quite young. But in terms of the increasing age, there's an increasing level of depression. I must stress that depression is a spectrum disorder. It can be that people have temporary sadness, that's part of the human condition. But when it is sustained and it continues on and on, then it is a major depression. So we need to differentiate between what is the normal human condition or sadness as a reaction to life events, and when there is ongoing or longer term symptoms and therefore a diagnosis of depression. When we talk about depression, we divide it into these 6 clusters of depressive symptoms. So there's obviously the mood, which is a sustained sadness with a lack of pleasure and irritability. And it's interesting that in women, the irritability is more commonly described, and often described by partners or spouses or family, etc. That irritability is often seen as just bad behaviour, whereas in fact it can be a symptom of an underlying depression. The obvious and common symptoms of depression are what we call vegetative symptoms. This is where there is biological change to sleep patterns, biological change to appetite, with either a loss or an increase in appetite. A change in weight, again, either a loss of weight or an increase in weight, and a loss of sexual drive. Then there is the third group, which is cognition, which is all about the higher thinking. So there are problems with attention, problems with memory, negative distortions regarding the self. I'm terrible at my job. Everyone thinks I'm pathetic at what I'm doing. I look ugly. I'm pathetic at everything. I'm hopeless. That's a negative distortion regarding the self. But it can be a negative distortion about the world. The world is a terrible place. There is nothing good here, and there is no future. So these are the distortive sort of thinking. Impulse control, where people feel impulsive and can direct that against themselves or others. And so this can be suicidal ideation, suicidal acts, or homicidal thinking or acts. Behavioural changes, so problems or poor motivation, a loss of interest in those things that normally would be interesting to the person or that they would find some pleasure in, those things disappear. And a tiredness. Again, there are differences in the expression of tiredness, but the common sort of description is that of being bone weary and mind weary. There are a number of physical side effects, physical effects of depression, and that includes headaches, stomach aches, muscle pain, constipation, and general movement retardation. So people just don't move as much. Now, if the person has 5 or more of these symptoms for at least 2 weeks, then they will be diagnosed as having a major depression. And that's when all the treatment modalities get activated for this sort of constellation of symptoms. Why does depression occur? We know that there are many life events that can create the scenery for depression. Losses of any type, loss of loved one, loss of ending of a relationship, loss of job, loss of anything, any type, loss of prestige. All these losses can lead to a depression. Traumas can lead to a depression. Life stress, and I mentioned migration as one of the life stresses, but general other stresses, and physical illnesses. Add that to a genetic predisposition. We know that there are that depression can run in families, and then you have this constellation of the causes to lead to brain biochemistry changes, brain structural changes, that then result in the depression as a major clinical disorder. Again, this is a functional magnetic resonance image of a person's brain. This is a control subject, a healthy subject. The red and yellow areas are the areas of activity when the person was given a task to do. It's a memory task, so remembering a certain number of objects, and then you ask the person these questions while their brain is being scanned, and these areas light up, which means that there's good activity in those parts of the brain. The same tasks and activity were given to people who have depression. So these people, these patients with depression, as you can see, the areas of activity in their working memory or their capacity to have memory and higher functioning and planning is severely limited in severe depression. So again, this is a real brain disease that we're dealing with. There are changes all over the other parts of the brain, and particularly, as was mentioned earlier, the hippocampus, which is a deep structure in the middle of the brain that is particularly related to memory, has changes in depression. The brain biochemistry changes are marked, so there's constant, or there's changes in the noradrenaline levels, which is related to the symptoms of pleasure loss, weight loss, insomnia, agitation, retardation and tiredness. And there's another neurochemistry system called serotonin, which is related to memory changes, impulsivity, emotional changes or problems, and ruminative thoughts. Ruminative thoughts are where the person just constantly thinks about all the things that they didn't do, that they should have done better, and so on. There are hormone changes, and we've heard about the cortisol, which is the stress hormone, and there is a great rise in stress hormone and blunted feedback loops. So there's a major change in all the hormones, including disruption in the sex steroid area. There is a change in thyroid function and also growth hormone. I've been working in the area of estrogen as a brain protective agent, and in situations such as menopause, where there is a drop in estrogen, depression is quite marked and increased. There's a 16 times increase in depression around the menopause. 16 times is quite a considerable increase. Just a brief talk, there's family studies that show there's a 2 to 3 times increased risk in depression in families, and particularly in first-degree relatives, and it is greater if the depression comes on at an early age or if there are recurrent episodes of depression. We do use pharmacogenetic tests, in fact, to understand with the genetic side of things which medication might be useful, and this is a particular importance because up to date the practice of using antidepressants to treat depression has been hit and miss. It's here, try this medication. If that doesn't work for 6 weeks, then we'll change that medication. If that doesn't work, we'll try another one, and so on. So in a lot of ways, it is important to limit the sort of length of suffering if you're going to be having to use an antidepressant in patients who are very severely unwell. So this is an important development. The antidepressants that are in common use are these acronyms, so the serotonin drugs, the noradrenergic drugs, and the reversible MAO inhibitors. Important to match the drug with the symptoms, and that doesn't happen very often. And then you can have people who are suffering from a particular type of set of symptoms in depression, and they're actually on a drug that doesn't have an effect for them. Now, a lot of that is very commonplace, but I want to talk about specifically more about women and depression. Women constitute the greatest percentage of the population who receive treatments for mental illness in most societies. So you'll find that women in any survey, population survey, have twice as much depression compared to men. And we have a number of surveys that actually show this. In particular, women aged 25 to 34 have almost twice the prevalence of anxiety and depression compared with men. This is a particular problem because, as mentioned, in most cultures, obviously women have still got the major role of caring for children and for caring for the older generations, usually. And this means that when a woman is depressed or unable to function, it's not only she who is suffering, it is often the ripples on both generations. Now, I don't have the slides here for this because I wasn't going to speak about it, but I think since we've covered the other areas, I would like to mention some of the things that are happening for women in Australian society, but also in other countries around the world, which is the violence against women. There is a personal safety survey that was done in Victoria in 2008, and the data from that personal safety survey is quite startling. It shows that, in fact, 19% of women living in Victoria have experienced physical or sexual abuse in the 12 months prior. So this is quite a high figure, that is 19% of Victorian women. And the figures about such things as stalking or unwanted attention makes that percentage rise to something like 27%, which is a very high percentage of the Victorian population, and it's mirrored in the Australian population as well. I have a women's mental health clinic, and we see women with mental illness, and I have to say that in the last 2 years, the figures of the numbers of women that we're seeing who describe some unwanted attention or violence or some sort of sexual abuse have really been escalating. And what this does, particularly in the early ages, if a girl experiences abuse, is that it sets up a lifelong pattern of a particular constellation of symptoms that are very poorly understood. This is a condition called borderline personality disorder, which is a ridiculous name because it doesn't mean anything to anyone, but it is actually better understood as chronic post-traumatic stress disorder. So what we're seeing is younger women, and in fact we're also seeing women who describe it retrospectively, that they're coming along in their 30s and 40s, and they experience a very great anger, a rage, and they're not sure how to express that, and often it is expressed by cutting themselves or burning themselves or putting themselves in harm's way, so self-harm. There is also a description of fragmentation within this person, that she will often say things like, I can look in the mirror and I don't recognise who is looking back at me. I don't feel whole. I don't feel as if I have any understanding about who I am or what I am. And the anger that is directed inwards with the self-harm, when we trace back the origins of that, is actually the anger that should be directed at the perpetrator of the abuse. And often what has happened is that the assault or the trauma has happened many, many years back, and it has been sort of buried, so that the actual cause and effect are quite distant. The other thing that this person experiences is intermittent major depressive episodes. And it doesn't respond, this kind of condition doesn't respond particularly well at all, really, to standard antidepressant treatments. In fact, some of the antidepressants can make the agitation worse, because this person also has very high levels of anxiety. And you can understand that somebody who has experienced an assault or a trauma at a young age is kind of living in fear for a very long time. Even at a subconscious level, they're living in fear. And we describe the analogy of the person who's kind of tensed up. Every muscle is on alert, every sense is on alert in case there is another attack. And we have households in Melbourne where this is an ongoing issue. We're seeing more and more of the situations where there are single mums trying to raise their kids, and in particular raising their daughters, although it does happen to boys as well, but lesser extent, but it still is this issue of this woman struggling to raise her children, and often in the situations where there is drug abuse or alcohol abuse, and there are many partners or sort of very short-term sexual contacts for the woman, then these men are in the household in a fleeting way, and particularly with drug and alcohol, there is disinhibition. And it's the adolescent girl around 15, 16, or even younger who is at risk. This is the scenario that we're seeing. And unfortunately, it's getting worse, not better out there, because there are many more cases of violence against girls and women presenting. I also am part of the International Association for Women's Mental Health, and I represent Oceania, which is the Southern Hemisphere. And in talking with my colleagues from around the world, and we have conferences, we had the one in Lima this year, it is a similar situation and worse in some places. And I have to say, the situation for Indian women is a dreadful situation. We have all seen the reports. And again, there is a great problem of violence against women. And one of the things that does is propagates this condition called borderline personality disorder, but it is in fact chronic post-traumatic stress disorder, with many ripples into the area of depression. It can be misdiagnosed as depression, it can be misdiagnosed as anxiety disorder, and it leads to this non-positive outcome for the woman. And the worst part about this is that in a study that was done by Avon in the UK, that's Flash is the author, F-L-A-S-C-H, in 2011, they studied 28,000 pregnancies, and they found that women who were assaulted, abused in pregnancy, in fact, have a major depression increase. But not only that, that through a genetic mechanism where there is a gene-environment interaction through the serotonin transport system and the genetics, that experience of violence is actually transmitted into the developing fetus. So the developing baby is born with a greater propensity for depression and for this particular condition, borderline personality disorder, so that we then see that this is a kid who has particular problems with memory and with concentration, because that's the other part of this syndrome, is a difficulty with concentration. You can imagine if the person is always living her life as if she's on high alert, then she's not able to calm the mind enough to allow new knowledge and learning to be part of her experience. So she gets behind in education. She feels bad about herself already because she believes that she caused this particular assault at one level, that this is the belief, even though it's not logical. And this is then transmitted down the generation. So again, as my kind introductory speaker said, societies that don't value women and don't value the need to provide safety, respect, equality for women are putting future generations as well as that generation and population at risk. And I think, while we might sort of look at the situations abroad and sort of think that the problems are worse in other countries, and there are problems, in our own neighbourhoods in Melbourne, the safety survey has shown that in fact violence against women is a very significant problem. And until we can actually conquer this, we are going to be sort of fighting uphill battles to help people who are then experiencing, women who are then experiencing depression and this rage response. Because of course then you have secondary problems which are drug and alcohol problems, where drugs and alcohol are used to try and get some respite from this internal chaos. This is a fractured personality because they have not had the capacity to integrate the sense of self. So this is a problem that we're really facing right on our doorstep, and we're facing worldwide until we can actually help to improve the situation about the non-violence and to become a more non-violent society, whichever country we're talking about. I want to talk a little bit about the menopausal situation. This is another obviously it's a natural progression for women, and the average age in Australia is 51 years. It happens earlier in Asians, in thin people, in vegetarians, and in smokers. This is not a disease, it's a normal physiological change, but there are many impacts, so that we have the situation with workplace stresses, relationship issues, teenage children, and sexual issues that impact for women at this middle age. I'll take you to the psychological changes because these are the changes that are happening hormonally, but the results, particularly psychological, are important to understand that at this point in time, and it's often in the mid-40s rather than at 51, because the brain changes for menopause in terms of the hormone impacts happen about 5 years earlier than the body changes. So at about 5 years before 51, so in the mid-40s, we see a number of women who have increased depression, and it can be the first time that they have ever experienced depression. So we have a number of women who been perfectly well during their earlier lives, and all of a sudden at about 45 start to develop a major depression. And that really the shift in the brain chemistry because of the hormone shifts is what's behind this particular situation. Irritability, anxiety, and the particular low self-esteem. So again, this is a time when many women start to think about their changes in themselves and talk about low self-esteem. So there are a number of physical symptoms as well, and combined with the psychological symptoms, this can be a really awful time for middle-aged women to navigate through. Also, obviously, it impacts on her family and in her workplace and in many quarters. And it's really important that menopausal depression, we're developing work looking at perimenopausal depression to try to get a better handle on this and to actually intervene with hormone treatments rather than straight antidepressant treatments. SSRIs are given very freely in this age group, and it really actually has significant negative effects sometimes. It actually causes more problems than it helps. So again, some of the natural therapies are very important. Sleep is absolutely vital. Women experience great sleep disturbance because of hot flushes and so on, but with sleep disturbance comes the problems of concentration difficulties, memory difficulties, and worsening depression. So sleep and anything that we use natural therapies and so on. So I know I'm running out of time, but I just wanted to highlight some of the specific issues for women and the types of work that is described here in terms of yoga obviously can provide a lifestyle improvement for women who are experiencing these sorts of depressive symptoms. And again, we are at the moment starting a project looking at depression through the Alfred Hospital of yoga as a treatment for depression. And I was very keen to hear about some of the other designs of your research, and I'll be talking to other experts here. I'm not at all an expert at all in the yoga side of things, but looking for any of these sorts of treatments without side effects that can be helpful for both men and women. But I make a plea that maybe through such things as yoga and consciousness raising, that we can have a more peaceful, less violent society, and therefore, in a global sense, improve the quality of life for women and for men. Thank you for your attention.